Assalamu alaikum. The short clinical station day. First scenario. Male patient, 65 years old. Please examine his hands. You can start it away. Here you go.
Okay. The first of all, wash my hand and then ask the patient. I am Dr. Al-Mahdi. I am here to examine you. If you feel any pain, please let me know. Okay, and put the hand of the patient in the pillow. The first of all, inspection if there's any deformity, if there is muscle wasting, and after that, see the palm of the hand if there's any palmar erythema, if there's any scar.
First, what deformity are you looking for?
If there's any boutonniere deformity, swan neck deformity, ulnar deviation.
There is ulnar deviation.
There's ulnar deviation. Okay. And
what other deformities you are looking for?
Z deformity.
Z deformity, yes.
Okay. And after that, if there's any, I examine the patient. Also, they see the nail. If there's any nail biting by the inspection.
No nail biting.
Okay. After that, examine the patient if there's any swelling, if there's any effusion, swelling distal or proximal or metacarpal joint.
Yeah, there is.
There's a swell. Where's the site? Unilateral or bilateral?
Bilateral.
Okay. And then
in which joint you think the swelling will be?
Yes, I want to check if there's any proximal or metacarpal and the rest.
Okay, what do you want to see in the wrist? The swelling?
Yes, I palpated if there's any swelling.
No swelling in the wrist.
Okay, and after that to check if there's any redness, any hotness. Check the temperature into the both hand and the proximal and distal.
Yeah, there is warm. The hand is warm in MCB and PIPs.
Okay, and if there is any tenderness?
There is tenderness in the same joints.
And then check if the skin, if there's any skin tightness.
No skin tightness.
Okay, and then ask the patient to check the movement by do the finger ask the patient to the movement. The first of all, ask the patient to close his hand about my finger.
Okay.
الهاند grab.
Yeah. There is an affection.
Okay, and then ask the patient to move his finger from each other and try to keep the finger close to each other. And then ask the patient if there's any weakness.
Yeah, no weakness.
Okay, and then ask the patient to do the thumb up and try to move the thumb down.
What you are looking for by this movement?
Yes, the looking for if there's any weakness في الثumb briefs longest briefs مش عارفة نسيت. Okay, for the medial nerve. Testing for the medial nerve muscle.
Okay, which muscle?
Which?
Yeah.
And then ask.
Okay.
And then check the sensation into the thinner and hypothinner.
Okay, this is what I need to do. Okay.
And after that, do the bray and reserving bray.
Looking for what?
Looking if there's any pain. Ask the patient if there's any pain before. After this, if there's any pain by the tapping at the rest. And then do if the patient do not have the pain, do bray and reserving bray.
Okay, what you are looking for by this movement?
Looking if there's any pain.
Okay, there is pain. What do you? Okay, there is pain.
And then examine the elbow if there's any rheumatoid nodule.
There is rheumatoid nodule in the elbow.
Okay, and then examine for proximal myopathy.
No proximal myopathy.
And then ask the patient to check the function of the patient by patient picked up the pens.
There is difficulty. He can grip the pen, but he is not strength in the grip.
Okay, and then examine the face if there's any pallor, if there's any jaundice.
There is pallor.
Examine the mouth if there's any cyanosis.
No cyanosis.
Examine the chest if there's any basal crepitation for basal crepitation.
There is basal crepitation. What do you think? Okay.
Ask the patient to cough.
Yeah.
Change it or not?
The crepitations not change.
And examine the second pulmonary area if there's palpable second heart sound and parasternal heave.
No.
And then examine the abdomen if there's any palpable spleen.
No palpable spleen.
Okay, 6 minutes already, but I will add 1 more minute to try to finish your examination.
Yes, I am finished my examination.
Okay. Can you bring your case?
This is a gentleman, 65 years old, on examination, presented on examination. There is deformity. There's deformity, ulnar deviation, and Z deformity, and also there's a swelling into the proximal and metacarpal pharyngeal joint with hotness and with sign of arthritis, with sign of synovitis, and also there's rheumatoid nodule. And carpal tunnel positive. There's most probably known case of rheumatoid arthritis was presented with a complication like lung fibrosis based on the patient presented with the crepitation is not changed with the cough.
Okay. Can you tell me the rheumatoid arthritis extra joint manifestation you are looking for?
Extra joint, yes, and also the patient the pain. Extra joint manifestation like the patient like episcleritis and episcleritis, dry keratoconjunctivitis sicca, lung fibrosis and anemia, and splenomegaly.
Okay.
And axial subluxation.
Okay. What the treatment option are available for rheumatoid arthritis?
Treatment option, the patient pharmacological, non-pharmacological, patient education and counseling, physiotherapy, occupational therapist, and also regarding the treatment of patient during the attack, you need into the painkiller and steroid for short term. The best treatment for rheumatoid arthritis, DMAR in form of methotrexate, leflunomide, sulfasalazine as a thiopurine.
Okay. And what biologic used in rheumatoid arthritis, you know?
Yes, if the patient use the DMAR, one of them methotrexate for the 6 months, and the patient is still not improved, can I start biological treatment like tumor necrosis factor and interleukin 1.
Okay. Can you tell me before starting the biologic, what the examinations you want to do for this patient?
Yes. Before started biological, needing to do research about the TB and hepatitis B.
Okay. And what is the difference between scleritis and episcleritis?
Scleritis, there's the pain. Episcleritis, there's no pain.
Okay. And just a minute. check the other questions. Last question. Okay. We'll talk about this. Okay. I think, yeah. What is the cardiac manifestation of rheumatoid arthritis, you know?
Cardiac manifestation of rheumatoid arthritis increase the risk of ischemic heart disease and precordial infusion.
Okay, thank you. Finished my questions. I have time still?
Yeah, 20 seconds.
20 seconds.
Yeah.
Okay, I think I didn't have more questions. Can you mention, okay, in these seconds, can you mention the rheumatoid arthritis, the longest standing or rheumatoid arthritis feature, complete features in the hands?
Yes, rheumatoid arthritis in feature of hand, bilateral involve. Yes, bilateral, symmetrical, involved with the proximal and the metacarpal pharyngeal joint with deformity, and also yes, with the deformity and rheumatoid nodule.
Okay. Okay, thank you.
Mhm.
Well done. Very good. And you cover most of the case. I think you did very well. Regarding the extra articular manifestation, you mentioned most of them, but it's still pleural effusion is one of the extra manifestation as well. And in this, and also you mentioned already the cardiac manifestation. Okay, splenomegaly. If you find patient with anemia and splenomegaly, what do you think?
Felty syndrome.
Okay, what is the manifestation of Felty syndrome apart from this?
Splenomegaly and skin rash and anemia and neutropenia.
Neutropenia, yeah. Okay, very good. Okay. We talk about scleritis and episcleritis. In episcleritis, what else? What other autoimmune you can find episcleritis?
Yes, inflammatory bowel disease, sarcoidosis, inflammatory bowel, Behçet disease.
Okay. Okay. I think you did very well. You examine the hand and you take permission from the patient. You detect that he has manifestation of carpal tunnel syndrome, and you also mentioned that the extra articular manifestation of this patient and the treatment. I think I don't have more comments.
Yeah. Sorry. Thank you, Dr. Maida, Dr. Rasha. Suppose this station to be short for neuro or chest or abdomen or cardio. But I think you make it like mix between long and short. Suppose here to examine the hand as neurological, right? But in this way, you examine as long case. So the station or the session is supposed to be for the four station as clinical. So either cardiac or neurological or chest or abdomen. It's okay.
Yes, but I think just only for search for complication, not detail, just only auscultation, the basal, if there basal crepitation. There's
What I mean, Dr. Asha, you will not have a station like this. You make it like mix. You bring patient for long with history taking and you examine his hand for the rheumatoid arthritis, which is not in the BASIS exam. The BASIS exam will be either neurological examination, cardiovascular, or chest or abdomen. Even if they ask you to examine the hand, you will examine the hand neurologically, not for the rheumatoid or the manifestation of rheumatoid or joint pain. You got it?
So rheumatoid arthritis will not come as
No, no,
short
no, no, no,
case,
no, no, no,
you
no.
mean?
Totally. Maybe in the Irish manner, they can bring the such patients as a short. But
Mm.
in the UK wise, they bring the four station, and in Irish they are calling it musculoskeletal. But again, it's with the history taking, not as a short doing steps of examination.
Mhm.
Okay, but they don't
You
have
mean
the
there's no
mandatory.
rheumatoid hand?
No, 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 no.
Uh-huh.
They
Uh-huh.
don't have in base in the Irish. They can bring either chest or abdomen or neuro or cardiovascular, not a must to have four stations. In comparison to the UK bases, they bring the four clinical station as short neuro and cardiovascular, chest and abdomen. So you will never have hand examination alone as long case or rheumatoid. No, it would be neurological examination of the hand. I
Mm.
expected to mention hand with something
Neurological.
neurological exactly. So some sensation affection, motor affection. I expected to have the ulnar palsy because you said there is a ulnar deviation. But it's okay. I left the discussion just to continue and complete the examination and the discussion. I think yeah, we can bring this such case with long history, taking history and 3 minutes or 4 minutes to do the examination, not 6 minutes. It would be more okay
Mm.
to examine for 6 minutes, but it wouldn't be as short station. Okay.
Mhm.
You got it? I think there is
Mm-hmm.
misunderstanding. You didn't know about the stations and the carousel of paces. That's why I corrected it. Anyway, I left you to finish the discussion, but in paces wise, you will not have such case. If they will ask you to do neurological examination of the hand, means you will examine the three nerves, median, ulnar, and radial.
For the nerve
Median
pulse, you mean, yeah. Uh-huh.
for neurological power.
Yes, nerve
Yeah,
pulse. Mm-hmm.
tone,
Mm-hmm.
power, reflex, coordination,
Reflex
sensation.
sensation.
Exactly.
Okay. Mm-hmm.
So it would be the same steps of any neurological examination in the hands, in the legs, or
Mhm.
this is in the neurological as a basis wise. Or cranial nerve examination. Sometimes they are bringing cases like this. Okay. Anyway,
Mm-hmm.
as a discussion for the rheumatoid, everything was okay. Yes, perfect. If you want to do another case as hand neurological, or you want to do another case between Dr. Rasha and Dr. Maida, just to do the citation as needed and as the routine, you can do. Or Dr. Rasha can give the case to Dr. Maida, and Dr. Maida can prepare another case as neurological. I don't know what Dr. Rasha prepared. What case you prepared, Dr. Rasha?
Yes, abdomen.
Abdomen? Okay.
Mm-hmm.
So we might do it as mix. Or if you can prepare another case, Dr. Maida, you want to do it as abdomen to have a discussion about abdominal station in both scenarios. It's okay. If we have time, we can do it.
Okay.
Uh, okay. But after you finish Dr. Rasha case.
Okay.
Okay. I had a question here in the chat box. I think Dr. Ilaf. She asked how you can mention DMARD sometimes with the time, and you used to say DMARDs. It's okay. It's not something prevented to mention, but it would be much better if you say disease modified agent for rheumatoid arthritis. This is the
Mm-hmm.
abbreviation, as well as DMAMS for the multiple sclerosis. So it would be disease modifying agent for multiple sclerosis, DMAMS and DMARDs. You can say it in abbreviation. I think it's accepted as the abbreviation, but better to mention the complete name. This is regarding this question, Dr. Ilaf. Z deformity, swan neck deformity, boutonniere, ulnar deviation, all this supposed to be mentioned whenever you have rheumatoid arthritis patients. If positive, you will mention the positive finding first. If not there, you can mention them as negative. I couldn't find the other deformity or other rheumatoid arthritis deformity. You can name them by name if he asks you. If not, It's okay. So you can say, I couldn't find other deformity of rheumatoid arthritis. He might ask you, doctor, what do you know about other rheumatoid arthritis deformities? Now the time to name everyone. Okay? As already mentioned between Dr. Maida and Dr. Rasha, you can repeat them. Okay, and the last, yes, I know, but I am just wondering, Dr. Ilaf, I'm wondering because the candidate say DMARS, like it is okay to say that. Yes, I think it's accepted abbreviation. And you just read the letters. It's not like hala. What I mean by abbreviation, something you can mention it, which is accepted to pronounce it. So hala, yes, HLA, but you cannot say hala. Okay, in DMARS, I think it's a universal abbreviation, DMARS medication. It's known for every rheumatologist. He can say DMARS. Again, if you know the abbreviation, better to say it incomplete. If not, and you are panic, you are stressed, that's it. To mention the abbreviation better than not to mention anything. Okay, let's start the... Yes, Dr. Huda. Let's start the second scenario. As abdomen
Yes.
examination, right?
Yes. Patient 6 years old, please examine his abdomen.
Okay, so hello, my name is Dr. Maida. First, when I enter the station, I will wash my hand. My name is Dr. Maida, one of the medical team. Can I confirm I confirm the patient identity, then I explain, I have asked to examine your abdomen, and this will involve looking, feeling, and listening to your tummy. Is that okay?
Yes, doctor.
Okay, then I export the patient from the nipple up to the pubic symphysis, and then I let the patient flat with the armpit tight and head on one pillow. I will looking around the patient if there is anything specific, and then I ask the patient, if you have any pain while I'm examining you, just let me know, okay? I will stop my examination. I start by general inspection. If the patient alert or distress, then I will have general look. If there is, if the patient look jaundice in his eyes, I mean generally from outside, and I will look for if the tummy there is any scars, if there is any
little bit jaundice, and there's a scar, a G-shaped scar.
Okay, and is the abdomen distended?
No.
Okay, then I will start my examination by examining the hands. First, I will examine if there is any tremor. I will ask the patient to stretch his hand if there is any visible tremor, and then I look for any clumping or any coloonychia or leukonychia. And then I will, if there is any Dupuytren's contraction, and looking for palmar erythema, and then I will examine the pulse. If it is the bounded pulse, examine the pulse both side, and then I will expose the elbow for any fistula, and then I will
no fistula.
Okay, then I will examine the eye for jaundice and pallor, and then look
no
for
pallor.
Okay, and then I look for the temporalis muscle. If there is any temporalis muscle wasting, then I examine the parotid gland. I ask the patient to open his mouth, looking for the mouth hygiene, and ask him to protrude the tongue if there is anything in the tongue, and then I will go down to the chest, looking for any spider nevi from the chest in front and behind. And then I will look for if he has any gynecomastia. I ask the patient to raise his hand a little bit to look under the axilla as well.
No.
Okay, then I will start the examination of the abdomen. You said that there is G-shape scar. Okay, this is by inspection. And then I will examine, then I start palpation, and I will, if there is any pain, just let
No
me
pain.
know. Okay.
No pain.
Okay. Then I will examine the deep examination. I will examine for the liver and liver span. Then I will examine to the spleen, if there is splenomegaly. And
No
then,
splenomegaly. But the
okay,
liver is palpable 1 centimeter below the costal margin.
so the liver span, I percuss for the liver span. Okay.
Liver span.
How much?
12.
Okay. And then I will look if it is smooth or irregular.
Smooth.
Okay. And then I will palpate for the kidney to see if it is palatable.
No.
And then I will examine for the, then I will examine for ascites, if there is any ascites.
Negative. Negative.
Okay. And I will ask if I can complete my examination by examining the PR examination. And then I will examine the lower limbs. First, by inspection, looking for any scratch mark, or this is by general look generally. And also I will examine for the lower limb edema.
1 minute left.
There's no lower limb edema. There's no scratch mark.
Okay. Then I will, I think I complete my examination. Inspection. I will look for ascites as well. I will examine for ascites if there is any ascites.
No ascites.
I think I complete my examination.
Presenting your finding.
Wait, sorry, Dr. Rasha, do you want to examine other limbs? You examine the upper limbs and the abdomen. You want to examine other things?
I examined the lower limbs.
You examine already? Okay.
Yeah, I examined the lower limbs already.
Examine, yes, already.
Lymph nodes? Any plan to examine lymph nodes?
Yeah. I can examine the lymph node as well. I will examine the cervical lymph nodes and the also the axillary lymph nodes and inguinal lymph nodes, if there is any enlargement.
No.
Okay, time is up now. You can start presentation.
Sorry, the age of the patient, 60, yeah?
60 years.
This 60 years old gentleman, I examined the abdomen of this gentleman. He has thing of jaundice and G-shaped scar. Otherwise, examination was normal. My differential diagnosis, this patient has a surgery. It may be open cholecystectomy or liver surgery or biliary tract surgery. Yeah, this is my presentation.
The scar
Or
for
liver,
cholecystectomy.
or liver donation can be, or liver transplant, I mean.
Yes. Okay. You mean this the patient liver transplant?
Yeah, this is a possibility of this G-shape scar.
Okay. Okay. What are the findings of the graft? The graft. Okay, you seem the graft is functional or non-functional?
Okay, so yeah, I need to ask about. You need to examine for tenderness. And it's enlarged, and I will see sign of inflammation. That's it, I think.
Okay, regarding this patient, the graft is functional or non-functional?
I think the graft is functioning because there is no tenderness.
Okay. What are indication of the liver transplant?
Okay, chronic liver disease, if the patient has chronic liver disease secondary to hepatitis, alcoholic, non-alcoholic hepatitis, or acute liver disease like fulminant liver failure.
Okay, regarding this patient, what did you think about the cause of liver transplant?
Given his from the examination, there is no sign of chronic liver disease, to be honest, and the only thing that he has sting of jaundice. Sting of jaundice can be sign of graft dysfunction as well, but again, there is no tenderness, and most probably in his age, I think about chronic liver disease.
Based on what?
His age. His age, and I can't find any other sign of chronic liver disease, to be honest, apart from the jaundice.
Okay. If the patient was high blood pressure, did you think why this patient has high blood pressure or uncontrolled blood pressure?
Not controlled, do you mean?
Can you explain why this patient uncontrolled high blood pressure?
Okay. This patient, there is many causes for that. One of them that he may have hepatorenal. Also, I can't find, sorry.
Okay. Did you check if the patient have any sign of immunosuppression using any medication like immunosuppression use?
Yeah. I need.
Okay. Okay. What are contraindication of transplant?
Okay. If the patient is alcoholic and is still taking alcohol, and okay, and if the patient this is the main thing. If he has other no, I don't think there is other thing contraindicated for liver transplant apart from if he is alcoholic and is continuing taking alcohol.
Okay. What are complications of liver transplant?
Medication, rejection, graft rejection. Also can be complication of the medication itself. And like the cyclosporines and medications complication. So the complication can be secondary to medications or secondary to rejection.
What are the prognosis of liver transplant?
I don't know.
Okay, still have time?
No, it's already passed. Time is up, and 1 minute 45 seconds added. Okay, now you can comment, Dr. Rasha.
Okay, well done, Doctora, but there's something. You must check the sign of patient G scar. You mean the patient liver transplant. You must to looking of the sign of immunosuppression,
Yes.
like gum hypertrophy, like the patient. Yes, like the patient, you want to check the blood pressure at the end. And also, you must to check about any flapping tremor. You check about the fine tremor, but
I check
yes,
flapping tremor.
Okay. You don't check the lymph node? Okay. Regarding this patient, this for liver transplant, the jaundice may be related to the liver transplant rejection, or maybe related into the other cause, because the patient just only have one sign of the liver rejection, because there's other sign is not presented, like jaundice, like ascites, like encephalopathy. Okay, you check the all other sign of a chronic liver disease. Regarding this, the patient liver transplant, but there's no any sign suggested a previous of a chronic liver disease. For that, the patient is the most common cause of the liver transplant, acute cause, like drug, like paracetamol overdose. Because the patient don't have any sign, suggest the patient have a chronic liver disease. Most probably, the cause of liver transplant, acute cause.
Mhm.
Mhm. الأذر contraindication of liver transplant, البيشنت alcohol, patient drug abuser, patient malignancy, البيشنت uncontrolled infection, البيشنت severe comorbidity.
Mhm.
absolutely contraindication, relative contraindication, البيشنت HIV, البيشنت advanced stage, البيشنت cholangiocarcinoma psychological problem. The prognosis of the liver transplant, prognosis good, 10-year survival, 70%.
Okay, 70%.
Okay, 70%. Regarding the complication, acute rejection, increased risk of the infection, biliary stricture and leak, and also most common cardiovascular complication and renal failure, and side effect of the immunosuppression, and also recurrent the organ disease. Okay, you mean I think if there's any case of liver transplant, making the case like renal transplant, looking for the primary organ, looking for the patient of the side effect of medication like immunosuppression, looking for the patient the graft is rejection or no. Another difference between renal transplant and liver transplant, the renal there's primary site of dialysis, like looking for the fistula and and catheter into the neck, but into the liver transplant there is no any primary organ. The first patient is the primary liver transplant. The same approach, you mean the same approach.
Mhm.
Mm-hmm. Looking for thing immunosuppression, organ disease, graft rejection, الاسايتس والانكيلوباثي والجوندس.
Yes.
But well done.
Okay, so what I'm going to ask, yeah.
Yes,
So
if
it will
patient
be
there's no any
similar
sign
when
of
the patient have liver rejection. That means the same as if he has chronic liver disease. I mean decompensated liver. It will be similar.
What?
If he has rejection, the sign will be similar to decompensated liver disease that he has.
Exactly.
Yes,
Failure,
like ascites, yes, encephalopathy, ascites, jaundice. Yes, the same liver decompensated liver disease. Yes.
Plus pain, tenderness at the site of rejection.
Yes, pain and high body temperature.
Yeah.
Okay.
Okay. Thank you, Dr. Rasha.
Regarding the scar, بس I ask
Yeah.
regarding
Continue.
this,
Yes.
regarding two scar ممكن يكون Mercedes scar or يكون G scar. في الباست medicine السكار كان G shape scar. فboth scar can be presented. Not
Yes.
only Mercedes-Benz scar. Okay.
Rooftop as well. Rooftop scar. Roof scope,
I think
G-shape.
Mercedes-Benz is car nowadays.
Yeah, they are not doing Mercedes-Benz anymore because it's major and horrible scar. Either G-shape or rooftop. So you will find Mercedes-Benz two limbs, the both horizontal limbs without the vertical limb. This is called rooftop scar. Okay, so Mercedes-Benz scar without the vertical limb. It would be only two vertical limbs. Plus, or either this or J-shape or the rooftop J-shape or Mercedes-Benz. These are the possible scars with the liver transplant. Anyway, you will find any major scar from side to the side of the patient with many clips. Many clips. It would be very horrible scar. You will never forget it. Okay. Okay, I will try to arrange the answer for Dr. Maida because she forget and she mentioned only And I prefer not to say only, Dr. Maida. You don't know, better to say I don't know rather than saying only. For example, the contraindication. You said the alcoholic liver disease only.
I know only what I know.
Okay, if you said what I know, yes, okay, but don't say only. If you said what I know and others I cannot remember, it's better to say I cannot remember. Okay, so don't say the only I know. I remember the alcoholic liver disease, for example, and I cannot remember the others. I'm not sure. Okay, because once you are saying what I know or the only I know means you didn't read about others. But there is a lot of contraindication. By the way, try to make your answers again systematic. Don't give anything. You can say relative and absolute. Even the start of your answer will give the impression to the examiner that you know how to answer, even you don't know more about the answers. So absolute contraindication means I will never forget about liver transplant. Relative contraindication, I can think about liver transplant if these things happened. Okay? Simply, I will try to make it simplified more. What do you think about the surgery or about the liver transplant? So it is something related to the surgery
Mm,
or related to the baseline of the patient condition or related to the preparation of the patient, right?
mm.
Let's talk about everyone and you will give me example by yourself. Let's start with the surgery itself. What do you think the contraindication to do surgery in any patient?
Contraindication.
Yeah, any patient you want to do
Okay.
surgery?
If yeah, if the baseline of the patient, how it looks like, and infection. This is the complication of the
No,
surgery.
no, no. Even infection, one of the contraindication. Active infection, one of the contraindication. But I'm talking about the surgery. Easy thing to think about and to give a reason and contraindication about is the surgery. You cannot do the surgery for the patient. I cannot take this patient to the surgery. Give me examples of contraindication to take patient to the surgery, to the OR.
Bleeding.
Yes,
Mm.
coagulation profile, coagulopathy. Why not? I cannot open the patient, right? I cannot put
Yeah.
a blade or I cannot do any incision. What
Mm.
else? So you
Uh,
can think about surgery
Bleeding, active,
itself.
as we said, active infection, bleeding. Um, what other things like unstable, a patient unstable, like if he has a heart comorbidities, heart disease or
Exactly. This is
anything
just
else.
what I want to. Comorbidity. Patient has a lot of comorbidity. Ischemic heart disease, lung disease, end stage liver disease, end stage renal disease. So why I will transplant him?
Mm,
I cannot even give him anesthetic. This patient
mm,
be under general anesthesia, and you know the general anesthesia has a lot of contraindication and a lot of complication if patient already went to OR. He might have arrest, cardiac arrest on table. So what the
mm,
benefit of the surgery? You will put a risk on the patient and the donor for nothing. So
mm,
the most easy contraindication or contraindication to think about is the surgery. I cannot take this patient to OR.
mm,
The bleeding profile, abnormality in the labs, investigation,
mm,
even comorbidity, obesity. What do you think if this patient morbid obese? I cannot give him anesthetic. Even I cannot put him in the table because of morbid obesity. By the way, it's one of the contraindication. So you have to think before answering. So you will give a lot instead of saying one only, you know,
mm,
simply. Okay, this is regarding the surgery itself.
mm.
What other medical? So let's divide them as surgical and medical. Medical. What do you think the medical contraindication to do transplant for a patient?
Yeah, as Dr. Roshi said, in this case, alcoholic, if he has
Yeah.
metastatic disease, if he has
Mhm.
chronic kidney disease,
Yes, exactly. Advanced cancer. I
advanced
cannot.
cancer. Mm,
Infection, ongoing infection, HIV. Okay. Simply, you can, as I said, you can think and you give the answer. So, alcoholic patients insisting to continue alcohol. This is contraindication, absolute contraindication. I cannot
Mm,
transplant and he will have again relapse or he will have cirrhotic liver disease. So, what the benefit?
mm,
This the first. The active infection, patient ongoing active infection, HIV patient, he will have definitely he will have infection after transplant. Why? Because he will be more immunosuppressed. So what the
mm.
benefit? I will put him on immunosuppressed indication and he's already immunosuppressed rather than the
بس
infection.
دكتور بس معلش ال HIV relative contraindication because the patient can take medication.
Yes, I know. I'm talking about general, not relative and absolute. I'm trying to make it wide causes to think more and to give more reasons or contraindication rather than saying I don't know or I cannot remember. Okay. Yes, HIV, it's one of the relative, but it's one of
Mhm.
the contraindication, regardless the division of either absolute or relative. Okay, back to the medical cause. We mentioned already the cancer, right? Cancer also patient is having cancer, ongoing cancer. What the benefit if I transplant? What else you think related to the medical?
Apart from this
Yeah, we
three,
mentioned. Yeah.
okay, also comorbidities, the same thing, like
Okay, comorbidities here at the comorbid. Okay, what one more you can remember from the medication itself? You are going to prescribe a lot of medication to those people. How guarantee you will be sure this patient will take this medication in compliant way? So
okay,
non-compliance or mentally retarded patient. Oh my God. You'll transplant to mental retarded patient, even he cannot cope with his daily activity or with his daily life activity.
but
You got it?
yeah, but I mean, like if he has any learning disability, there is someone will be responsible. There is care responsible
I
about
am
him to
not
manage
saying,
the thing.
no, I'm not saying it's absolute contraindication. I'm trying to give you a lot of contraindication examples in order to remember any of them. Don't give the relative and absolute as a division because you might forget what to put here and what to put there. But if you
Mm,
can say surgical related causes or medical related causes, or if you remember the absolute and relative, it would be much better because absolute means you cannot do the surgery. Okay, absolute, one of them, the alcohol. You can say it as example for one of the absolute, alcoholic liver disease or insisting to drink alcohol. This is contraindication and it's by book, you have to say it. If the patient refuses stop alcohol, you can say you are not candidate for transplant. I cannot transplant these people, these
mm,
patients, right? So you can say it as an example for absolute. Why? Because you might forget what are the absolute, what are the relative.
mm.
But the main and the most strong contraindication is absolute contraindication is the alcohol intake. Okay. Let's go to the other question. What other question, Dr. Rasha ask you? The complication. Yes, I like also how to systemize the answer for the complication.
Mhm.
Okay, try to make it as general and specific. Okay, general means related to the general health of the patient. So infection, cancers, right?
Okay, so complication, we can start like from the any surgery, complication of any surgery, like infection, bleeding, and
Okay, this is good. Yeah, good to remember also the complication of surgery.
yeah.
Any biliary injury or trauma to any other nearby organ. It's good also to remember. So you can say general and specific and complication related to the surgery. I agree.
Complication related to surgery,
Yeah.
complication related to medication, complication related to the to the transplant itself.
Okay, I agree.
So
I
complication
agree
for
with any approach to mention
now I
the
just making the
highlights.
thing
Yeah, to mention the highlights, then you can mention
more
under
easy.
everyone. Yeah, example.
Mm,
So
okay.
as you said, let's start with the surgery. As you said, so you can say it in the surgery. either
Infection,
contraindication
bleeding,
or
and
complication. Yeah, two I, two Bs: pain, bleeding, infection, and injury to nearby organ. Okay, what other, maybe also related to anesthesia itself?
yeah.
Patient had anesthesia, comatose, or any lung disease, for example, had pneumothorax surgery. No one can tell you, no, it's wrong. Okay, now the role for the other thing you already mentioned.
Graft, no, rejection, graft
Okay,
rejection,
that's the
and
graft itself. Either
graft rejection. What we said, like
the rejection
right.
always give the second or the most related rejection infection. The same
Mm,
even pronounce rejection infection, right?
yeah, and complication for medication, like
Okay, this one you can make it as different
so,
category, and you can give a lot of complication only related to the medication side
mm,
effects. And I think, and I agree, and I am sure you can give at least 5 medication with every side effect for each medication.
mhm.
So give me the names and the possible side effects. Give me 5 medication.
Five,
You will find.
five a lot. Okay, like tacrolimus,
Okay, and the most common is.
hypertension, and it can cause neurotoxicity. This is what I know about it, and
Remember T,
nephrotoxicity as well.
always T for tremor. Tacrolimus tremors.
Tremor, yeah. It can cause tremor and hypertension, nephrotoxicity, and neurotoxicity.
Okay.
Cyclosporin, gum hypertension,
Yes. Gamma hypertrophy and
and hypertension as well.
eye hypertension, hyperkalemia,
Mhm.
hyperglycemia, all increase, I think hair growth, all increase can be associated with cyclosporin. This is what I remember from even part two. Cyclosporin mean increase a lot of things. Okay. What
Uh,
is the third medication? By the way,
uh,
the third medication you can give many side effects, and it's very common immunosuppressed medication. Immunosuppressant.
corticosteroids.
Exactly, steroid. You can write a page of
Mm,
of complication of steroid. You can even spend the 4 minutes talking with the examiner about the complication of steroid. You can gain the marks only if he asks you, give me the complication of medication about steroid itself. So give me at least 5 complication of steroid.
hyperglycemia, I mean diabetes,
Okay.
hypertension, can
Yes.
cause Cushing's syndrome,
Okay.
and osteoporosis.
Yes. Okay. Gastric ulcer,
It also steroid-related
psych
psychosis.
psychosis, gastric ulcer, skin bruises,
Mm,
right?
yeah.
See, you can eat, at least take time for the steroid itself.
Mm,
Immunosuppression, infection, gain weight. Still, you can even find a
yes.
lot. Okay, back to the immunosuppressant. What the fourth medication you know?
Uh, Azathioprine.
Yeah,
Mm,
okay. One more.
um,
But it's not common, by the way, for the liver. It's, I think, common. No, no, it can be. M- Myco,
mycophenolate.
yeah. And also, this is common for the renal, what I remember also.
Mm,
But still, you can say it's one of the immunosuppressants, okay?
mm,
I think, see how many medication you gave, how many side effects. So try to categorize your answer, not only give
mm,
the most common. Okay, so if you say the most common, you will forget the others. But try to, if you categorize, he will ask you even in if each category, and try to start with the most common or you are familiar with. For example, related to the transplant, you can say related to the what's complication related to the transplant, rejection, infection, even recurrence of the original disease, one of the complication, right? You can spend time talking about the type of rejection. What are the types of rejection? Hyperacute, acute, and chronic. What are the most common infection in immuno or transplanted patient? Cytomegalovirus, parvovirus. So you can talk a lot rather than saying, "This is what I remember. This is what I know." Okay. If you start to categorize the answer, you will give a lot of answers. Okay, I think these were the questions and the scar, the type of scar and what are the possible scar. Yeah, one more question. The differential diagnosis of J-shape scar. What you could find or what other possible surgery might be done by
They
J-shape?
liver, any liver surgery, like
Okay, good.
cholecystectomy,
Transplant. Exactly. Gallbladder or surgery to the liver. Liver, including transplant or even liver abscess. Or you said cholecystectomy, yes, gallbladder, any surgery related to gallbladder, or
biliary surgery.
biliary surgery, anything related to this area you can mention. Even the cancer itself, they might release or remove or excision of a cancer, right? Okay, that's enough for this topic. One, sorry, before asking others, any question, Dr. Rasha, Dr. Maida?
No, I think it's covered. You touch exactly what I need because maybe I am not regulating this in my mind. I feel like I don't know, but if I regulate it and categorize in
Exactly, yes.
this manner,
This
it
is,
be
yeah.
more easier to remember.
I know it would be prior to the exam because maybe you don't have the diet, or even you have the diet, but still you have time. But even practicing from now, believe me, in the exam you will answer by heart like you are memorizing everything, you are ready to answer. Even with the stress, you will not forget. But if you postpone these things before the exam by 2 weeks or 3 weeks, the stress will make you forget everything. Even regulating the answer or categorizing the answer, you will forget everything. Whenever the examiner asks you how to manage this patient, you will say immunosuppressant. Oh my God, this is the only way to manage. No, there's a lot of counseling, education. So, okay, so it's the matter how to be calm, how much calm you are, and to give an answer while you are calm. Because I'm calm, I can give good answer, systematic and organized and categorized answer, for example. Okay, this is the way how to be clever in the basis. Believe me, wallahi, some doctors they are not that much excellent and perfect, but they know how to control, how to answer in a clever way. That to show the examiner that he is familiar with the patient, he is familiar with the management, talking with the patient, talking in communicating with the patient. So they can know from the way he's talking rather than testing his knowledge. Okay. Any question, Dr. Rasha, Dr. Maida? Okay.
No.
Okay, thank you. Any question from others? Hepatic
Or
artery thrombosis, Dr. Hoda. Yes, yes, one of the complication, thrombosis. Vessel problem or vessel condition, vascular condition. Why not? Could be. Yes, someone was talking. Sorry to interrupt him.
yes,
Or
I'm
here
asking about scar shape in transplantation.
in transplantation, Dr. Salma. Yes, in the liver.
J shape liver or pins. There is pins shape scar.
Yes,
This also for transplantation. Both of them.
yes.
Oh,
The three of them, Mercedes Benz. So you will have the three limbs. You know the Mercedes Benz mark.
yes.
Okay, so this is common for the old, not old, the old fashion because they are opening the chest plus the tummy. Okay, nowadays or recently they do the J shape, so it's little bit horrible and confused and major. And the third one, so Mrs. Benz J shape rooftop. Rooftop simply it's a Mercedes-Benz without the vertical limb. Imagine it. You can even draw it on your body. So you will just make a parallel scar beside or parallel to the costal margin in both direction without the vertical limb of the Mercedes-Benz going to the chest.
Mm-hmm. Okay,
Got it?
clear.
Okay.
Okay, thank you.
Okay, Muslim. Any other question? We can move to the next scenario. Any question from other?
Just I can add because it's my case in exam. So if there is the splenomegaly, they will ask you what's the cause of splenomegaly in this case.
Perfect. Yeah. The splenomegaly in the transplanted patient.
Yes, it can be related to original disease. I answered like that.
Yeah,
I got good
yeah.
marks in this expectation. Yani, it can be related
Good.
to the original
Okay.
liver disease before the
Yes,
transplant,
exactly.
or it can be complication like lymphoproliferative disorder because
Yes.
long using of immunosuppression. It can be also like related to any
Infection.
infection because this
Yes,
patient prone to
malaria, immuno,
infections.
exactly.
Yes.
Yeah.
Yeah. So
I was
he asked me what you will need to check for this splenomegaly. I told I can check the lymph nodes like that.
exactly clinically examining the lymph node. And investigation-wise, you can screen for all infection screening plus lymphoproliferative or myeloproliferative. Okay.
Can I ask another question, please?
Yeah, sure.
What liver condition can recur after transplant?
Yes, good question. What do you think? I will ask you this question.
I think hemochromatosis can come back.
Yes, exactly.
That become reinvented by vein section.
Yes.
Probably primary biliary sclerosis, I think.
Infiltrative disease.
Infiltrative, all right.
Yeah. Even cancer. Patient had
And
cancer and he
virology, the
had
first
recurrence
cause,
cancer.
virus
Yes,
still in the
infection.
blood.
What about the autoimmune, like primary biliary sclerosis?
Everything, yeah, is susceptible.
And also the fatty liver can return back. All the causes, I think, can return
Yeah.
back in liver.
You can, yeah.
I think there is two, specifically there is two causes that can, two common that can recur, but I'm not sure.
Okay. Anyway, what I remember hemochromatosis, yes, as infiltrative,
Yeah.
because yeah, something is systemic and infiltration is happening even with the after transplant.
All right, thank you.
Okay, so if you think you can give an answer.
Sometimes you are just don't want to give like like a wrong answer.
Yeah, I agree not to give an answer which is maybe wrong. If you suspect it's wrong, don't mention it.
Yeah.
But remember that most of the autoimmune or something outside the liver can recur back, like
Exactly.
infiltrative or cancer,
Yeah.
or even
I think
autoimmune.
the two things is most common in kidney transplant, not in liver, because
Yeah,
liver,
I think,
it,
yeah,
all
this
the
question.
condition
Yeah.
it can recur.
So what's in the kidney transplant can come back?
I think the most common is good buster, I think.
Yeah, good question. And focal segmental, I think also one of the, if I'm not mistaken. But
Alright.
yeah, good basture, one of them, because the antibodies against it's the same matter.
Yeah.
Some recurrence of the antibodies against the glomerular membrane, so it would be back attacking the transplanted kidney.
All right, thank you.
Yeah, we can even refresh that in the WhatsApp group. But what I remember, yes, good basture, one of them, anti-glomerular membrane antibodies will be back and attacking the new kidney. I think the other one, if I'm not mistaken, focal segmental. If someone can confirm, please, or let's confirm it later on.
Yes, it's focal segmental.
Okay. There is more advanced question. What is the most common to be recur back? So one of them, I'm not sure also. Is it the focal segmental to recur back commonly or the anti-glomerular brain?
Dr.
So there is,
Bassem,
yeah.
for the kidney, most common rejection after transplant, it's Albert, the recurrent, yes,
Uh-huh.
it's most recurrent. It's ايش what
Mesangial,
capillary.
mesangial capillary.
Yeah, glomerulonephritis. Second, AGA nephropathy, and the third, focal segmental glomerulonephritis.
Thank you so much. You can write
Thank you,
them.
doctor.
Yeah, write them.
Yeah. Okay.
IgA, the first one is mesangiocapillary, then IgA.
Mesangio, the first one, then the AGA and nephropathy, the
Exactly.
third one, focal segmental.
Yeah, so good pasture,
Not written.
no recurrence, but
No
I
recurrent.
remember anti-glomerular antibodies coming back
This
with
for rejection, Albert. Yes.
exactly. Yeah.
Albert.
So the antibodies coming in Albert disease, yes,
Yes, Albert, not
but it's not good
pasture.
pasture. Yes, thank
No,
you.
no.
Yes,
So
you.
rejection. Okay.
Yeah.
So
So
it can
the
cause rejection. Okay, not recurrence and rejection. Yeah.
rejection in Albert, why? Because of anti-glomerular membrane antibodies for the kidney or against the kidney in Albert disease, because the same antibodies present in the same body.
Okay.
In order, the most common recurrent disease after transplant of the kidney in order: mesangiocapillary, IgA nephropathy, and the focal segmental glomerulonephritis. Thank you, doctor. Thank you so much. Any other question? I like when the session is interactive like this. So a lot of questions with answers, so everyone will get benefit. I'm not that much perfect to say everything because I'm not even preparing the topics. So I am trying to recall, but please, if you are sharing with me, so everyone will get the benefit. Anyone has a question before moving to the next scenario, or is it satisfactory for you today, Dr. Maida, Dr. Rasha? You can do another case. Did you prepare a case, Dr. Maida, as abdomen? Is it late for? Is it?
It's okay if Dr. Rasha, she want to do one.
You will give
Okay.
her,
Yeah,
right?
yeah,
Okay.
yeah.
So others can attend, so we can proceed. The
55
time.
years. Okay, 55 years old man examines the abdomen.
Okay. No answer means agree, right? So let's continue. Then the third case. Actually, it's the second case as abdomen and as a short because there was mistakenly discussed short case in the beginning.
Yeah.
Okay. How much his old? His age?
55.
35 male.
55. 55.
55.
Okay. Male, 55
Yes.
years, presented with abdominal pain.
Examine the abdomen.
Oh, okay. No presentation, just examine. Okay.
Okay, is this a short or long?
No,
Short.
short. Say it's short.
Short.
Dr. Rasha, ready?
Mm-hmm.
Here you go.
Okay, hello, my name is Dr. Al-Mahdi. Can I take permission from you to examine you? If you feel any pain, please let me know. And then looking the general look of the patient, the general look of the patient, the body belt, and after that, looking the general surrounding. I started the examination from the hand to see if there's any clubbing, any leukonychia, any palmar erythema, any fine or flapping.
For the general inspection, patient looks cachectic.
Mm-hmm. Okay. If there's any respiratory distress.
No.
Okay. If there's any clubbing, leukonychia.
There is colonychia. But
Okay.
no.
There's any palmar erythema.
No.
There's any fine or flapping tremor.
No.
Okay. I want to check the arm if there is any AV fistula.
No.
Okay. Eye if pallor and jaundice.
Looks pale.
Pale. Okay. I look the mouth if there's any cyanosis.
No cyanosis.
The neck if there's any lymph node.
There is lymph node. There is lymphadenopathy, cervical lymphadenopathy.
Okay. Okay, then examine the patient if there is any pitting edema,
Lower limb?
lower limb, yes.
No lower limb edema.
Okay, and then inspecting the abdomen, ask the patient to take a deep breath.
Mm-hmm.
Okay, then examine the inspection to the abdomen if there's any scar.
No scars.
Okay, if there is any scratch mark.
No.
Okay. I want inspection the chest if there's any gynecomastia, any spider nevi, axillary hair.
No.
And then do superficial palpation
Mm-hmm.
and deep
No pain.
palpation if there's any organomegaly.
Yes. Where you will palpate?
I want to examine the liver, started from the right iliac fossa, and then go up. And then after that, check the liver span.
Okay, liver normal.
Okay, and after that, started from the right iliac fossa to go the midline to cross the midline to go to check the spleen.
Okay, there is a mass.
There's a mass. Okay, and after that, examine the kidney if there's any palatable kidney.
Kidney not palatable.
Okay, regarding the spleen, how many centimeter below the costal margin?
You find a mass. How can you say this is spleen?
Okay, start. I want to check if there's how much from the costal margin, and then do percussion,
Mm-hmm.
and after that auscultation the spleen.
Okay.
And after that, I want to check if there's any ascites.
No ascites.
Okay. Okay, I finished my examination.
Okay. Present.
This is a gentleman, 55 years old, and the general look the patient cachectic and then comfortable into the bed. There's pallor, and there's leukonia, there's bulbable cervical lymph node, and splenomegaly. Most probably, yes, this diagnosis is lymphoma. You need yes, lymphoma, and also I want to complete my examination to check the vital sign and examine the hernial orifice and examine the hernial orifice and do BR examination.
Okay. How can you say this is spleen?
Okay, regarding the spleen is okay. From the patient, the spleen is crossing to the midline, and there's splenic notch, and there's can I get above and dull into the percussion.
Mm-hmm. Okay. What is your differential diagnosis apart from lymphoma?
My differential diagnosis, lymphoproliferative. The second differential diagnosis, myeloproliferative. The third differential diagnosis, a chronic liver disease. Apart from, there's no stigma of a chronic liver disease.
Okay. Okay. So which lymph node you examine the cervical lymph node? Which other lymph node you want to examine?
Yes, I want to examine the axillary lymph node and inguinal lymph node.
If there is any other lymph node you need to examine?
Axillary lymph node or inguinal lymph node. Mediastinal lymph node, but not examined. Okay, مش عارفة.
Okay. Okay. You put the differential diagnosis that lymphadenopathy, splenomegaly with lymphadenopathy. You put lymphoma the first thing, and what other thing?
The second thing, myeloproliferative. The third thing, chronic liver disease. Apart from there's no stigma of a chronic liver disease.
Okay. What infections can cause lymphadenopathy with enlarged spleen?
Infection cause lymphadenopathy, like Epstein-Barr viral causes lymphadenopathy and enlarged spleen.
Okay. In tropical area.
In tropical area, you mean leishmania?
Okay. Yeah. Leishmania is a
Mhm.
differential diagnosis. What other?
Uh,
Okay.
Leishmania and malaria.
Okay. And what you will do for this patient?
Apart from the basic investigation, CBC, LFT, inflammatory marker, I want to do abdominal ultrasound to confirm my diagnosis. And also I want to peripheral blood film, lymph node biopsy, and bone marrow examination.
Mhm. Good. I think I didn't have any more questions. It's still I have time.
Yeah, 1 minute and 10 seconds. If you can ask about differential, already you asked about differential, right?
Yeah.
She mentioned all the causes of splenomegaly. There is what's called isolated.
There is another differential diagnosis.
And don't forget to ask about the huge splenomegaly, the cause of huge. Did you ask?
Yes, huge splenomegaly, myelofibrosis, and CML, huge splenomegaly, and leishmania and malaria.
Okay. The only thing that okay, and you the investigation you did the investigation. We asked about the investigation as well.
Mhm. Mhm.
I think I have no more questions.
Okay. One more question. She mentioned that all viruses can cause splenomegaly.
No, not all the viruses.
Can you mention them, Dr. Rasha? The last question. What are the possible viruses can lead to splenomegaly or can cause splenomegaly?
The viruses, Epstein-Barr viral,
Yes, it's
and
important. What the other name of the disease?
the other name of granular fever, the other name of Epstein-Barr
And-
viral.
Yeah, and fever, and one more name. The last name?
Other name,
Infectious mono.
infectious mononucleosis. Okay. Mhm.
Yeah. Okay, what else?
Cytomegaloviral, بس I'm not
Yes.
sure.
Parasitic, you mentioned already the malaria, right? But
Yes.
Epstein-Barr, you have to remember. Okay.
Mhm.
Yes, I think it's enough. Yes, fair enough now. Dr. Maida, can you comment?
I think you did well, but there is, I think there is a lot of differential diagnosis still we need to mention. And according to this differential diagnosis, it will also, the investigation will be, we need more investigation for this patient. And I'm asking you specifically about lymph node to examine in a patient with huge splenomegaly. This is the condylar lymph. It's specific for Kala-Azar or leishmaniasis. So this is lymph node when it's enlarged. It will be tropical spleen, splenomegaly. Okay, so the differential diagnosis, if we go through, this is patient positive for both lymphadenopathy and splenomegaly. If we go hematological causes and infectious causes, the hematological causes, as you said, lymphoma, and also chronic lymphocytic leukemia can be a cause, and myeloproliferative disorder. And the infectious cause, as you said, Epstein-Barr virus and infectious mononucleosis, cytomegalovirus as well, HIV, and toxoplasmosis and tuberculosis. tuberculosis also from the infection, brucellosis, and leishmaniasis. The other inflammatory disease that there is autoimmune disease as well can be differential diagnosis in the case of in this case with generalized lymphadenopathy, but for less. One of them, SLE, it can come with generalized lymphadenopathy but mild splenomegaly. Rheumatoid arthritis, Felt syndrome. But Felt syndrome normally it's not come with lymphadenopathy, I think. Sarcoidosis, one of the differential diagnoses as well. Malignancies, any other malignancies for the lymph node, Castle disease and everything. Then that means the workup will be we'll do CBC and we'll do peripheral smear, and then we can do serology tests for the viruses, tuberculosis, HIV, cytomegalovirus, and everything. Then we need to, if we are thinking about lymphoma, we need to do at least chest X-ray or CT scan. We need to do abdominal ultrasound and CT abdomen. Then we'll go for the biopsy. Yeah, this is my comment.
Yeah, thank you, Dr. Maida. And well done, Dr. Rasha. I think she covered most of the finding as well as the examination or the examiner questions.
Yeah.
Yeah. Again, the topic of splenomegaly is very important. You should be ready for it, either isolated or associated with liver disease. Don't forget to mention the splenomegaly as a cause or as a complication to the chronic liver disease or cirrhosis as increase or portal hypertension sign, right? So we have
I think it's still the liver disease is still a differential diagnosis, but in this case, because it can cause liver
Exactly.
cirrhosis can be shrunk, but
Yeah.
liver span will be small and
shrunken liver, yes.
but I think if this is the case, there is sign of chronic liver
Exactly.
disease.
Yeah. So let's make them again in summary. Either splenomegaly with hepatomegaly, okay, and this you can mention the whole causes of hepatosplenomegaly: infection, infiltrative, or even I think cancer, infiltrative and cancer and infection. Yeah. Myeloproliferative and lymphoproliferative, you can mention, because lymphoma can cause both hepatosplenomegaly, hepato and splenomegaly. The second category for isolated splenomegaly. So the spleen you can feel without hepatomegaly. And this is already mentioned as an infection to the spleen with lymph nodes. Sometimes without with this liver, as we mentioned earlier, or you can say only confined to the spleen itself as an infection. Kala-azar and malaria and infectious mononucleosis. But don't say chronic myeloid leukemia, because chronic myeloid leukemia, one of the myeloproliferative, so you might have hepatosplenomegaly. And lymphoma as well can lead to hepatosplenomegaly. Infiltrative can lead to hepatosplenomegaly. So isolated splenomegaly, you have to specify something only related to the spleen. Okay. Back to the third category would be spleen with shrunken liver. You can say, yes, palpable spleen without liver as either normal liver or shrunken liver. Shrunken liver, so you can mention the whole cause of chronic liver disease as a cirrhotic liver disease. Any cause you can mention, but you have to have the finding or the signs of portal hypertension, as Dr. Maida said. So you might have caput medusa, spider nevi, gynecomastia, loss of axillary hair, ascites, and jaundice, of course, cachexia, muscle wasting. You have to find all the things. If not, you cannot say this is a portal hypertension or spleen related to portal hypertension. Don't mention it. Clear now for all? I try to make it as simple as I can. So either you will feel the liver with the spleen, this is hepatosplenomegaly, or you can feel the spleen without liver. Either the liver is normal or the liver is shrunken. Whenever you have portal hypertension or signs, so you can say this is splenomegaly due to portal hypertension because of chronic liver disease or chronic cirrhotic liver disease. Okay, this is
Mm.
simply or a summary diagram how to make a case regarding abdominal enlargement or abdominal discomfort or spleno or hepatomegaly in patients. Okay, either this or you will have transplanted liver or transplanted kidney or scar. So you can memorize all the case can come in pieces, but the most difficult point is how to palpate. Whenever you palpate and you felt the organ, you will get the case. Even they can ask you around the case, but again, you can gain a lot of marks. But if you didn't palpate and even felt the things, how you can gain the marks? So it depends on the. That's why it's called short clinical station. You will not take history. You will just palpate and use your hand to examine the patient to find the positive finding in this patient. The discussion will not be longer than like the long clinical case. It's 4 minutes only. When he
Mm.
starts to ask, he will ask you, "What's your finding? Present your case. What are your finding? How to investigate? How to manage? What's your differential?" Maybe 1 minute for each question. Then does the exam will be done. I mean, for this station. Okay. So it depends on your skill how to feel the organ, how to find the and pick up the findings. That's it. It's different than the long clinical consultation, how to take history, how to address the concern, how to examine the patient during, how to ask about social, how to offer support, how to be sympathetic, how to be empathetic. That's why this station 20 marks and the long is 28 marks. Any question for this station? Either the first case or the second case. Any question, Dr. Rasha, Dr. Maida first? As the president
No.
participants. Okay. Any other questions? Any doubts? Any missed? Clear for all? Any
Dr.
message?
Bassem, only the last question, please. Here, we cannot say direct the differential diagnosis lymphoma. Maybe it's most probably to say pallor and splenomegaly plus lymphoadenopathy for differential diagnosis. It's not more clear like this, or correct?
By the way, they don't need from you to say this is the diagnosis. How you
Differential. Yeah,
exactly? You don't have
yeah.
history. You don't have
So
symptoms.
if we said the pallor splenomegaly plus
Yes,
lymphoadenopathy for differential diagnosis.
perfect. So you are
Mhm.
suggestive a diagnosis. You are not
Yeah.
saying this is the
Then he
diagnosis.
will ask me what's the
Yes, exactly.
possibility for this one.
Yes.
Okay.
Unless you have a scar, the problem of a scar, you have to know the scar. Possibly and probably you have to know the case from the scar. For example, you have right or left iliac fossa mass, and you have a scar there. What do you think the case? You
It's
have to, yeah,
a
go
transplant kidney.
perfect. So you have to say this is transplanted kidney,
Mhm.
and you can get good mark in this. But be careful. It's not only a matter of what the scar is. You have to know what about the previous mode of renal replacement therapy, how is the volume status, how
Yeah.
is the patient condition, the immunosuppressants. You have to comment on these three things after mentioning your scar and your diagnosis. The scar is different. That's why you have to give the definite diagnosis. You cannot say a scar, for example. Yes, you can say it, but he will ask you most probably what is this organ, or what is this mass? You can say there is a scar and there is mass for differential, but you can say on top of them, most probably this is transplanted kidney. Why I said that? Because evidence by there is a scar for AV fistula, for example. There is a scar for shunt or catheter in the neck. I can feel palatable kidney. So I have all the evidence for a diagnosis of end-stage disease. So you can say like this. Okay, the liver transplant.
Okay.
I have a scar suggestive of liver transplant. Why you are saying that? Because this is the scar specific for it. But there is possibility to be scar for another major surgery, but most probably this is scar for liver transplant. So the answer always like this. You are trying to suggest, not to confirm. You don't have history to confirm the diagnosis. Clear?
Clear. Thank you, doctor.
Yeah, and this is different from the lung. The lung, you have to give most common diagnosis based on the history taking, and you have to have a clue to give him a diagnosis. You have deformity in the hand, for example, the first case today. Deformity in the hand with joint effusion, with interstitial lung disease, with, for example, sun exposed area rash. What do you think the case from the history and the manifestation you collect from the history? Most probably rheumatoid arthritis complicated with or associated with the systemic lupus. So I have a suggestion of, for example, overlap syndrome. But you cannot say from the examination only that I have overlap syndrome. How you can gain it, right? This is the difference. So in the examination or the short station, you can suggest, but in the long, you have to know the case. You have to know the diagnosis. Clear? Okay.
Clear. Thank you.
Thank you, Dr. Kinana, as well. Any question or suggestion? Almost the time is up for the session. Any question before ending the session? Okay. If clear and satisfactory for all, we can end the session now. Thank you, everyone. Thank you, Dr. Asha, Dr. Maida, particularly everyone attended today. See you tomorrow with long clinical consultation day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.